But we are so glad that you are all here. The commitment that you guys have made for the year just really sort of solidifies the dedication that the Colorado hospitals have to making birthing care better. So I'm going to go ahead and start moving on as people are joining us. Really quickly, just to show you our names and faces, you get a lot of emails from us, and you'll continue to get emails from us throughout the year. And sometimes just attaching a face to that email makes a big difference. Most of your emails will be coming from Cindy Comstock, who is our Fearless Program Coordinator. If those are getting caught in your email filters, please add her to your friendly list so that you can get her emails. Probably second most common is Gretchen Scholes, our data analyst. And so she also does a lot of communication with the teams about your data and making sure that, one, we're both getting it, and that we're giving it back to you in a timely and meaningful manner. And so these are the people who are really dedicated to making this year successful for you all. And I'm going to jump right in and just talk about exactly why we're here. I don't want there to be any misconceptions as to what we're doing in this program. We're here to address Colorado's C-section rates among low-risk birthing people. So in this graph, I made it, if you can't tell. It's a little homemade. What I'm showing you here in the top line, the zigzaggy line, is a pretty rough estimate of both the national and the Colorado average C-section rates for low-risk birthing people. In general, that goes somewhere between 24 and 30%, depending on geography. Colorado usually is between 24 and 25% for our C-section rate among low-risk birthing people. In the red line, I wanted to denote for you where the Healthy People 2030 goal sits. So again, for Healthy People 2020, and again, for Healthy People 2030, the goal for low-risk birthing people is that birthing facilities can meet and maintain an NTSB C-section rate at 23.6%. So it gives you a little bit of a visual here about where we are and where we would ideally want to be. The World Health Organization actually takes that even one step further, and they recommend that outcomes are not improved with C-section rates that are above 10 to 15%. And so that certainly is sort of a low marker in the United States for safe NTSB C-section rates. But I think it's really important that we visualize sort of where we are now, because it informs where we want to go. And so you can see here on this slide, where the SOAR collaborative lives, right? We live in this space between the Healthy People 2030 goal and where our current NTSB C-section rates are. And so to be clear, our goal is not to have no low-risk C-sections. We know that they serve a really important role to support maternal and infant health, but to bring our rates sort of more in alignment with where we should be. In Colorado, again, we do a relatively good job with our overall C-section rates, both for all birthing people and for low-risk birthing people. But what we have seen is that there's a wide range of C-section rates by birthing facility and by providers. And so again, our goal as part of this collaborative is to see if as a group, as a collective, we can work together to sort of decrease that wide range or that wide variation that we see in C-section rates throughout the state. So again, just to make it clear for you all, we have two goals here. One is to help us prevent unnecessary C-sections, right? For people who are still great, safe candidates for a vaginal birth, we want to ensure that they remain a candidate for a vaginal birth. And our goal is to make sure that for people who need a C-section for their health and their safety, that we make that the most patient-centered and safe experience that we possibly can. And so again, just to center us in the work that we're doing, this is exactly why we're here. On the screen here, you can see the Colorado NTSB C-section rate from 2016 to 2023. And as you can see, we've had our ups and downs. And compared to many of our peer states in the nation, we do an overall great job. But just to sort of like drive this point home, that red line there represents the trend of where we are as a state. We recognize this trend. Many of the hospitals who are participating in our program this year recognize this trend at their individual facilities as well. This is an excellent opportunity as a state for us to come together and be proactive in addressing this. And so again, that's why we're here. The trend is increasing. Colorado does a great job, but it's really important that we're proactive in addressing this and getting really in front of it. Let's go ahead and move on. I wanted to start with just a really brief case study. California gets a lot of love and attention just generally as a state in our nation. They also do an honestly really great job with NTSB C-section reduction. And so I just wanted to give you a picture of what another peer state has done as far as a similar program to where what we're doing this year and what outcomes they have. So California, just like Colorado, was sort of noticing that their NTSB C-section rate was slowly creeping up, and they recognized that from hospital to hospital, or even from region to region, there was a wide difference in the C-section rates. For example, Los Angeles had C-section rates as high as 33%, whereas the North Bay region, San Francisco Bay Area, maintained C-section rates in 22%. And again, this isn't a dramatic difference in population or geography or provider types, but what that speaks to is that those variations are opportunities for improvement. If one hospital, one region, one hospital system can improve their NTSB C-section rates, there shouldn't be large barriers for other hospitals to be able to learn those lessons and also improve their C-section rates. What they also noted is that negative outcomes weren't any difference between those hospitals. So if we talk about maternal sepsis, maternal transfusion, NICU admissions, right, there wasn't a wide variation in those outcomes among those. And so what it was telling them is that a higher C-section rate wasn't actually improving overall outcomes among those populations. And so they wanted to do something really important to address it. What they did is exactly what we're doing here this year, is they built a collaborative of hospitals throughout the state. They are a big state. We're not quite as big as they are. They had over 80 hospitals participate in their learning collaborative. And they did what we're doing, collaborative learning and instituting change ideas to address the leading causes of NTSB C-section in their state. These graphs are really impressive to me, right? Along the left-hand side, you can see that compared to the national average from 2016 to 2019, they made really dramatic decreases statewide with their NTSB C-section rates. And even more importantly, on the right-hand side that you can see here, they were able to decrease those NTSB C-section rates across all race and ethnicity categories. And so really exciting work that's come from them. We will continue to use them as a model among other states, right? Illinois has done similar work. Florida has done similar work. We're not alone in this work, and we will continue to learn from our peers. We actually met with the California team not that long ago, and now that they've seen overall decreases and are sort of maintaining those C-section rates in the ideal range, their next goal is to decrease those disparities, right? And to address more specifically, even though all of those NTSB C-section rates sort of in unit were able to decrease, there should not be vast disparities by race and ethnicity, and they're taking a really concerted effort in the coming year. I'm really looking forward to seeing the work that's coming out of their state. And I will pass it over to Victoria.
Thank you, Amber. Hi, everyone. I might be a new face to you all. I'm Victoria Garcia. I recently joined the team several months ago as a new quality improvement coach. So I'm likely to be working with your facility along with Amber. So good to see you all. I'm thrilled to see all the different facilities during the chat. So we wanted to talk to you a little bit at this first meeting about what a learning collaborative model is and really what you can expect from this meeting and from us moving forward. So as the name suggests and explicitly says, this is a collaborative, right? This is a touch point every month in which we're hoping that you can share your successes, disseminate information, debrief about challenges, innovate collectively, builds community and connection, sort of all the things. So it's really not our intention to just speak at you the whole time or deliver information in a one-way dialogue. It's really a bi-directional exchange and really a space that we want to cultivate of shared ownership and shared leadership. So if you have ideas for agenda items like guest speakers, activities, really anything, like please let us know. Your participation and your feedback is so celebrated and embraced, and we would just love to hear from you. And just believe that you all have such invaluable wisdom and important contributions to make. So with that being said, I want to practice what I preach. And I would love in the chat to know, like, what is one thing that you all hope to get out of this learning collaborative over the next year? And I'll pause and wait for some responses to come in. There's no right answer, by the way. It's not a trick question. Awesome. Okay, some responses rolling in. Yep, strategies to reduce C-section rates. I'm seeing, yep, better communication with providers and nursing staff. Oh, this is awesome. Sustainable ideas on provider engagement. Yeah, implementation tricks for sure. That can be really tricky. What's working? Yeah, great. This is awesome. New innovative strategies, what you're already doing. Yep. Awesome. Thank you so much. I mean, and this is not just like a one-time question. We will constantly ask you this. So just would love to keep in mind, just keep in mind that you can always contribute and give us feedback and really shape this space to be what is most valuable to you all. And thank you for contributing. Okay, passing it back to you, Amber.
Yeah, guys, keep putting stuff in the chat if you want. We will collect these ideas and use it to guide our year. That way we make sure that we're addressing the most important things to you all. Throughout the year, you guys, as part of the program, do get quality improvement coaching. And so we're going to launch the year with two of my favorite quality improvement tips. The first of those tips is that we should all be sharing seamlessly. That's the goal of a learning collaborative, which is that no one is here to hoard information. When people are learning things and having successes, we expect for you to share out so you can benefit your peers. These are your peers this year. So you can see here on the left-hand side, these are the hospitals who are actively working to reduce their NTSV C-section rates. You are all in this together. And on the right-hand side, the sustainability teams, these are hospitals who have actually been able to maintain a C-section rate at or below the Healthy People 2030 goal. And they are here not only so that they can continue those best practices that have led them to this type of care, but to share their knowledge with you. And so it's almost built in that you have mentorship from other hospitals who have already been able to achieve this success. You can see here this map. It's super exciting to me. Our current enrollment in this program covers about a third of Colorado births in the state. So 1 in 3 Colorado births happen at hospitals who are participating in this program. Guys, there are power in numbers, right? Like we have the power in this learning collaborative to shift the rate for the entire state. This is exciting to me. My second favorite QI tip here is that we should be stealing shamelessly. There's no reason to hoard ideas, right? And so throughout the year, we will be giving you our favorite resources, our best resources, learnings from other states, other hospitals, and our goal is to share them widely with you. If you guys have resources of your own that you've developed at your own hospital that have really helped you along with your quality improvement, we would love to collect those for you in a repository that everyone in the collaborative is able to use. These are a few of our favorites. Again, California has put out an extensive toolkit for NTSV C-section reduction. All of our work in this learning collaborative is guided by the middle picture here, which is the AIM patient safety bundle for cesarean reduction. All of the guidance that we give is directly from that bundle approved by ACOG, SMFM, A1, and ACNM. And then on the right-hand side is actually a homegrown resource that we created, which is a checklist that you all can use on your units to help guide the accurate diagnosis of labor dystocias. So labor dystocias are the leading indication for NTSV C-sections, and so they are a big focus of our program. We actually have stickers that you guys can put on your name badges at your hospital that are look exactly like this. If you come to the SOAR forum, you can get some. So if that's not a plug for your attendance at the forum, I don't know what is. Pass it back to Victoria.
Thanks. Yeah, we'll probably be plugging the forum quite a bit this hour. So I saw that a lot of you have already done this. Thank you so much. If you haven't already, just another shameless plug to make sure you change your name if it's still showing up as Sydney, because we'd just love to know who's who. And if you haven't already, I would love it if you could drop your name, your title, and organization in the chat. And one thing you love about what you do. And if you've already shared your title and organization, yeah, one thing that you love about what you do in the chat would be great to just get to know you all a little bit better. And CPC/QC stuff, you can do it too. All right, I see some titles coming through. Awesome. Thank you guys. You guys are awesome at the chat. Really appreciate it. And I know that could potentially be a pretty long answer. It's so fun to talk about what we love about what we do. But I see a lot rolling in. Yeah. So you guys will have opportunity again at the SOAR forum, hopefully to connect more in person. But I think this gives a nice idea up front about some of your peers in this group, right? Like we have a lot of facility representation across the state from rural providers and all kinds of different roles that you all play at your organization. And really what I'm seeing in the chat is a lot of shared motivation, shared values, um, shared love for what you do. So thank you so much. All right, let's go to the next slide. Okay, so we're gonna continue with the interactive portion. We were not just all talk when we said that. This is one of my favorite graphics. I love it so much. I think it's like everyone wants change, right? Who wants to change? Not so many people. Who wants to lead the change? Almost no one. Um, and I think it just illustrates, like, for those of us in this field, right? Like, change is really hard. It's even harder to embody and the hardest to lead. But you all being here in this cohort is really a testament to that. You are leading the change and you're here to do that. And we're so grateful for that and know how difficult it can be and what an uphill slog sometimes it feels like. So with that being said, we're gonna pop a poll in just to gauge sort of what kind of participation you've had in QI previously. And are they both up at the same time, Sydney? Okay, great. And then like how you might rate your knowledge on QI. Your answers are totally anonymous. We can't see who answers what. So again, no right or wrong answer. And I'll just wait a minute to see some of those responses come in.
Can
I
everyone
love this.
see the poll? There are 2 questions in it.
If you can't, let us know in the chat. I'm gonna give it like a few more minutes. Looks like a few of you have completed. Again, we can't see who answers what. Okay. All right, well, let's go to the next slide. We got like a diversity of answers on that, but the surprise here, right, is that even if you answer that you didn't have any experience or you feel like a novice with quality improvement, the truth is that you actually absolutely have participated in QI before, and you actually are already very proficient in it, believe it or not. I think quality improvement is often cast as sort of this like jargon-laced, complex methodology whose really primary application is in the healthcare space. And like the truth is that we're all quality improvement practitioners literally all of the time. So even outside of professional contexts, like if you've ever set and achieved a personal goal, like it's January, right? So I'm sure a lot of us have recent experience with this just in terms of like setting a New Year's resolution and thinking about what are the actionable steps I'm going to take to get there. Or completing a task, like if you've ever sleep trained a child or taught a dog how to sit and stay, like that's actually, you're engaged in quality improvement. So this is really something that transcends just the healthcare industry. But of course it has significant applications in the professional setting. And you and your team are already QI practitioners and that you're already engaged in practices, whether they're conscious or unconscious, that directly impact NTSV C-section rates. So the purpose of QI, like if we remove all the jargon and just distill it down to what it actually is at its core, it's a model that's here to define the practices and sort of help you chart which of them lead to measurable improvements in patient care. So you can think of it as a framework that can really just help you carry out change and identify what works and what doesn't along the way. And I like to say QI is it is a full contact sport in that it's really interactive, iterative. It's a process that involves a lot of experimentation and collaboration and systems thinking. And we'll dig into this a lot at the SOAR forum, and we might introduce some new terms to you, but just wanted to demystify that and really empower you as you enter into this cohort and into this program to think of yourselves as QI experts already. We're just here to sort of show you some of the tools along the way. All right, up next, we are going to send you off into breakout rooms to give you some opportunity to connect with each other. And we'd love to just get your gears turning a little bit about what your team or your unit is already doing and what you're doing well to reduce or maintain your NTSV C-section rates. And where is there room for improvement? Like, you all joined this cohort, right? So like, what are you thinking are some areas for improvement that you might like to experiment with and try out? Then this is a fun question, and I'm so excited to hear what you talk about, but we'd love to know, if you could only do one thing at your hospital to reduce NTSV C-section rates, what would you do? So I'm gonna drop those questions in the chat so you can access them while you're in there, and we're gonna randomly assign you so you can kind of meet each other. Okay, I think I sent it out. And let's do, so we said 10, yeah, for 10 minutes. Okay, so we'll send you off no more than 5 people per room, Sydney.
All right, sounds good. The rooms should be opened.
And we'll pull you back at 10 minutes.
Those who are co-hosts are in the main room and can hop to a room should you choose.
Thanks, Sydney. I think everyone got into a room.
We have a couple. Room 5 only has 2 people.
I'm so sorry, I didn't drop this in the chat when I should have. We will be using these at the SOAR forum as well. They're so cool. You can kind of take notes in real time. So it looks like some teams did that. So you can see some of the takeaways here. And for those of you who didn't have a link to the Jamboard, I'd love if someone could unmute and maybe share a key takeaway that you had from your conversation. Oh, Katie over at Cheever.
I can go. I didn't have the Jamboard link, so I was just taking notes. Some of the things that our teams on the call or on the group were doing well are getting physician buy-in. One person said they have a system for how they collect data and how they get into the system. That's been really successful for them, which is great because the other teams had said that one of their struggles is data, which we understand. Other things, a couple sites have midwives on the floor 24/7. A couple people shared that it's been really helpful to basically train nurses and midwives on labor support. So doing spinning babies, having peanut balls, helping the patients get into the different positions, tubbing, upright walking, and not doing early inductions, and not everyone gets Pitocin. Sometimes they do like cervical balloon or ripening, but letting the labor really progress as best they can. And I'll stop there.
Amazing.
Oh, one thing that I loved, Robin from UC Health North shared that they have been bringing awareness to the checklist to everyone about the needs to reduce their rates. And as they've seen improvements, they've been sharing with staff and providers on a monthly basis in real time to be like, hey, this is our data this month. These are our rates. And just really getting everyone involved, sharing with staff and providers the breakdown for the indication complications for cesarean and pointing out like, hey, these were because of failed induction, but those failed inductions met the labor dyssocia criteria, or this site has a similar population to this other site, but one is having way more like fetal heart rate tracing indications than another site, even though their patient population is the same.
Wow, that sounds like that was such a robust discussion.
I'll
That's
send you my
awesome.
notes. I was really taking them.
Yeah, thank you. And I'll be sure to drop the Jamboard when I should next time. And I see that Sydney just dropped the labor dystocia checklist in the chat, which I know came up in one of the groups I was circulating in. Anyone else?
Two things that are in addition to all of this that my group discussed. I was with 3 hospitals that have been involved in SOAR that are doing very well. And it sounded like some of the most successful means that they did is not only using the SOAR checklist, but putting the SOAR checklist in their electronic system. So it automatically pops up. No one has to go find a paper sheet. And then also all 3 of the hospitals have a pause on elective inductions. So
Awesome. Curious if anyone would be willing to share an area for improvement that came up or something they'd like to focus on.
I just wanted, this is Dr. Dawn Owens Robinson, in response to the first lady who took notes and listed spinning babies and having midwives. I spent 8 years of my career working with midwives, and it was a wonderful experience. And I think moving the patient has to be key. Flipping the patient, doing everything we can to help that baby get down in the pelvis is vital. I just wanted to agree with that in my experience. The 3 people on my call, the 3 hospitals are at the beginning phases, but I've worked with checklists. I came from Spectrum Health in Michigan, and we were evidence-based. Our order sets were the same, our notes were the same, the MFMs trickled the information down, and we followed. Case in point is how they managed Epic. It was a easier transition during that time because our leadership was good and everything was evidence-based, and we had checklists and criteria for things to be followed, and I think it'll make a difference, obvious by California's results.
Thank you. Yeah, we're really excited about the checklist, and I love some of what I've been hearing about how to really integrate that into the EHR, thinking towards how that can actually be used in clinical practice in real time. Oh, we have someone in the chat. Emily says, if anyone is willing to share their hospital's name. Okay. Regarding the pause of elective. Okay, yes, if anyone can answer for Emily in the chat. Okay, in the interest of time, I'm going to close us out, but this is really a preliminary dialogue, and we will continue to chat with you, and we hope that you connect with each other at the SOAR forum in several weeks. So we'll go back into the slide deck. And we're keeping an eye on the chat.
I'm trying my best, Victoria.
Oh, yeah, no worries.
You're welcome to go ahead and start talking about aim statements.
Yes, aim statements. So those of you who have engaged in formal QI before probably know aim statements very well. It's essentially a fancy synonym for a SMART goal, right? And really an aim statement is the first step to beginning a QI project of any kind. And it really just helps you define what you're aiming to achieve. And it's more specific than that. So it sort of lays out what needs to be improved, by how much, and by when. So I like to think of it as kind of like the North Star of QI efforts, because regardless of how a QI project unfolds, your team with an aim statement really always has an idea of the direction of a project, the desired outcome, and how success will be measured, which is huge. And I also think, in my experience, having that bedrock to touch into with the aim statement can really serve as a motivational tool that builds up a lot of team commitment, it guides your decision making, and it really sets the stage for evaluating impact, which is so crucial in what we're doing here together. So I'm going to drop this worksheet that we have. We're not going to do it today, but we very much encourage you to look through it before the SOAR forum, and think towards, if you don't already have an aim statement, this might help get your gears turning a little bit about it. And we also want to encourage you strongly to investigate what kinds of goals already exist within your organization around C-section rates and perinatal health. Your facility and your team might already have an aim statement that you could repurpose for this program or build upon or advance in some way. And finding that alignment between SOAR and sort of the mission and vision of your hospital can support a lot of leadership buy-in and resource optimization and sort of long-term sustainability for QI. So next slide. All right. So once you have your aim statement, like, you need to know where to begin, right? So now what? Well, these are the 5 domains that we think are the primary drivers of QI in the SOAR program. So I like to think of this, if you're a visual person like me, it's basically just a pictorial display, a depiction of the factors that really influence systems change and drive NTSV C-section reduction. So the expectations are not that you're performing at 100% all the time in all of these domains, but rather it's sort of a guiding framework that can help you hone in on change ideas that you really want to implement and identify tangible areas for innovation and action and improvement. So it's just a tool to sort of help you organize your ideas and focus your project. We will revisit this often, especially at the SOAR forum, which I keep mentioning, but it's just coming up so soon and we're so excited. We have a whole session devoted to this. We'll be really delving into a group exercise that can help provide some greater clarity and depth around these 5 domains, but just wanted to introduce them to you here for key pathways that can guide your QI implementation. And I will hand it to you, Amber.
Thanks, Victoria. We want to be clear that no quality improvement program is truly quality improvement without data. And so we think data plays a really important part of our improvement efforts. It helps to focus our attention, making sure that what we're doing is actually making a difference and to not waste our time. A few of you have already brought up data in the things that are working well and the things that your teams are hoping to improve at your sites. We just wanted to cover the very basics. Some of our teams are return teams. They're very familiar with our program and are already sort of aware of the data requirements, and some teams are brand new to us. And so I wanted to kind of start with the basics here. One is that participation in the program requires a data use agreement. It's our way of being really transparent with the data exchange that we're doing, right? What data we're wanting to look at with you, how we're using that data, how we're protecting that data for you. And so that data use agreement has to be signed by someone in your C-suite. We know that that can be a slow process sometimes, and that many of you are working on this actively. If you need support for getting your data use agreement signed, if you need more information about your data use agreement, please reach out to us. We'll be happy to kind of talk through the C-suite at your site if that would be helpful for you, but just know that it is a requirement for us to be able to look at your data with you in order to offer you the QI coaching. Second is that for this program, we're really focused on monthly data collection and feedback. As one of the sites already shared, that rapid cycle feedback is some of the most important and most effective ways to get your staff engaged in improvement efforts. And so in real time, sharing the most relevant data is what we want to help you guys doing. So data submission for this is a monthly affair. If you have not already identified someone on your team who is going to be the champion for your data and helping your team to collect it and help to submit it, I encourage you to identify that person. And then the next step is to reach out to Gretchen, who is our trusty data analyst. She helps us with all of the data collection, all of the data analysis, and how we give that data back to you in a way that informs your QI. She has open office hours. I really encourage you, especially if you are a new team to our program, whoever is your data champion, put them in contact with Gretchen. She is very great about making this accessible and as easy a process as possible for your team and making sure that you feel equipped to approach the data for this program. take advantage of that, please. REDCap is the HIPAA compliant data platform that CPCQC uses in order to keep your data secure. Your data submissions will come through that program. Gretchen can offer you an orientation if you're not familiar with REDCap. And again, make sure that you're aware of everything that you need to be doing data-wise. And one of our major data collection pieces is a clinical care checklist. Some of the teams have already mentioned this and the things that they've implemented at their site and they feel like have made a big difference in their NTSB C-section rates. We're going to drop our clinical care checklist in the chat now. My ask is that if you are not already using this checklist, familiarize yourself with it between now and the SOAR forum, so that you and your staff are sort of aware of the pieces that are really important for the clinical care for low-risk birthing people. This clinical care checklist also serves as your data collection tool. So it's very important not only to help guide evidence-based care of these patients, but to help inform your team and your quality improvement efforts, as some of the teams have already brought up. Even though I was saying that statewide and nationwide, labor dysocias are the leading indication for NTSB C-sections, that's not true of every hospital. And many of our hospitals are seeing that non-reassuring fetal heart tones are actually the leading indication. These clinical care checklists are helping us to capture that data. Again, that way your site really knows what you should be focusing on and not wasting your time or efforts on things that might not be true of your site. So look at the checklist. We're happy to field questions about it. If you're not already using it, I recommend that you print some of these out for your unit and encourage a few of your nurses to go ahead and start using these, right? To give you feedback. Ideally, every single low-risk birthing labor would use this checklist, at least initially in this program, to get you guys a better idea of what's going on at your site and to focus your efforts. We will revisit this checklist at the SOAR forum in more detail and talk about sort of why the pieces and parts are on the checklist and how that data informs your participation in the program. Speaking of data submission, you now have an opportunity for your very first data submission for 2024, and we're celebrating that for you. And that on a quarterly basis with our program, we have you guys fill out a very simple survey. And so this is the QR code to that survey. The survey should be filled out by one person in your program, right? So if that's a physician champion, a midwife champion, or a nurse champion, sort of whoever can speak most informed on your program and what's happening should be filling this out on a quarterly basis. You are welcome to take a moment right now or right after we finish this call to take a moment and fill out the survey for us. It is just an update on the processes and the procedures that are in place at your hospital to support patient-centered care, right? And so this isn't actually quantitative data collection. This is just a qualitative response to what are the practices that are happening at your site. Again, it can help inform us of what are the tools and resources that we can give you as a hospital or share between hospitals that exist to promote patient-centered care. So again, it should be very brief. Once you've done it, that's your first data submission of the year, and we applaud you. We will share out the link to this survey and a follow-up email as well, if you don't have a minute right now to finish it. We want to talk about what's next. So we have mentioned probably 100 times in the past 50 minutes, the SOAR forum. We have an in-person forum on February 9th at St. Joseph Hospital. And it is an excellent opportunity for all of the hospital teams who are participating in our program in 2024 to come together with some active collaborative learning time. We have expert speakers who are coming. We have panels that are coming to speak. We have active working sessions that we're going to have our teams do. It's going to be an excellent time together. It is a free forum for your attendance. It also provides CE. If you have not already registered, this is the QR code. Feel free to reach out to us if you have questions about it. We have monthly learning collaborative meetings. This is your first one. Those learning collaborative meetings from here on out are going to be on the last Wednesday of every single month of the year. If it needs to be changed due to a holiday, we will inform you at least a month in advance. But mark Wednesdays lunch hour, 12 to 1 o'clock. We will be here every single month participating in these learning collaborative sessions. We encourage at least one person from your team to attend these just to keep your team on pace with your peers in this learning collaborative. Every single person at your hospital and in your unit is welcome to attend these calls, but we ask that at least one champion is in attendance for these calls. And then finally, as part of the program, you get free quality improvement coaching. And so Victoria and I are going to offer that coaching in this coming year. We encourage you to go ahead and sign up for quarterly coaching sessions. If you generally know your unit's schedule for the next year, you are welcome to schedule either just quarter one or all the way through Q4 of 2024. We love the opportunity to touch base with you one-on-one, again, to talk really sort of granular detail about exactly what your hospital is doing and what you need and what resources we can offer you. And those QI coaching sessions are the best opportunity for you to get that really tailored coaching experience. And so reach out to Sydney. She has the calendar set and ready to arrange you all. At the very least, we ask that you go ahead and schedule your Q1 coaching session as soon as you and your team are able to. We have 5 minutes left. I'm going to wrap it up with 2 visuals. The first visual here is the diffusion of innovation model by Everett Rogers. Many of you might be already familiar with this model from graduate school days or bachelor's days. It's not new to many of us, but what it's talking about is sort of the stages that people go through when we're adapting changes or new innovations. And so as you can see here in red, I've indicated that those of you who are on this call and leading quality improvement at your sites, you guys are the innovators and the early adopters. You are the people who are leading the charge. You are on the front lines of bringing the most evidence-informed quality improvement efforts at your site. And as you can see, there's a chasm that happens right between you all and your peers that are the late majority, the early majority, and the laggards. We are here as a learning collaborative to help you cross that chasm, right? We know that there is often a gap between people who have the time and the will and the desire to make these improvements because it is work to make them, and then sort of that gap between the people who may not be as willing to change their behaviors. We are here to support you over that chasm, but celebrate the fact that you guys are in this early setting, right? You are the innovators, you are the people who are willing to disrupt and make positive change at your sites, and we're so glad that you guys have signed up to do that with us. The last thing I want to leave you guys with is what if you fail, right? Quality improvement is work. It does require effort, and not every single effort that you make is going to result in an improvement or be a success at your site. But what is the most important to us is that you are not going to have any successes if you give no attempts, right? We are here to attempt again and again with you to make improvements and to make the improvements that you are instituting successful with you. But our goal is to have many attempts and at least a few successes, and to share those successes with our peer hospitals. We're here to learn together. As a collective learning collaborative, we're going to make many attempts, right? That top left-hand square there is going to be full of many, many attempts across the state that are happening for improvement. And again, as a collective, that increases our chance of having many successes that we can share with each other. So wanted to give that as an encouragement to you. There's one question that we wanted to leave you with, and if you could put it in the chat, that would be great, because we want you to leave every single learning session with an action item. What is it that you're taking from either this learning collaborative call or your onboarding experience with this program, or even the conversations that you've had with your peer hospitals today? What do you plan to do between now and February 9th or now and the February Learning Collaborative call in order to advance this program? Nothing is off the table here. We want to hear any ideas that you have. Go ahead and put them in the chat. If you want to learn from your peers, go ahead and read through the chat as well. While you guys are doing that, I'm going to open up for comments, questions, concerns. We will leave the line open for anybody that wants to speak up.